Hi, I'm Jim Smyrniotopoulos, and this is another MedPix video. If you'd like to earn AMA CME credits, please sign into the MedPix website at medpix.usuhs.edu. Here is our disclaimer. Today's case is a 5-year-old boy who was knocked off his horse. He hit his head and he had a loss of consciousness. On clinical examination, it was determined that the patient's right pupil was dilated and non-reactive. Shining a light in the left eye made the left pupil react, and shining a light in the right eye also made the left pupil react. This is the classic appearance of a non-reactive or blown pupil. This indicates that the afferent optic nerve or second nerve is intact on both sides, but the efferent or motor nerve that would cause pupillary constriction, the third nerve, is not working on the patient's right side. What could cause this? An emergency CT scan was performed, demonstrating a large extraaxial mass lesion. In comparison to the normal image on the right-hand side of your screen, you can see the sulci are symmetric all the way around and the ventricles are symmetric. On the patient's image on the left-hand side, we see a large extraaxial mass lesion. This is pushing the ventricles to the side, causing herniation under the falx or subfalcial herniation. The extraaxial collection is hyperdense, consistent with an acute hematoma. The collection is biconvex and does not cross the attachment of the periosteum at either the coronal suture in front or the lambdoidal suture behind. This is the classic appearance of an extraaxial or epidural hematoma. We can see here in the cartoon that we have a biconvex hematoma displacing the brain and causing herniation under the falx. The ventricles are like shock absorbers, and the fluid is squeezed out of the ventricle before we have herniation. This again is an acute epidural hematoma. How does this cause the patient to have the dilated or blown pupil? As the hematoma expands, it begins to push on the brain. We have herniation of the cingulate gyrus underneath the falx, and the medial part of the temporal lobe, or the uncus, herniates into the opening in the tentorium or the tentorial hiatus, and it compresses the oculomotor nerve, which is passing through the same space. The trochlear nerve is also in a similar location, but it is oftentimes not affected. If we compare our cartoon with an actual MR scan in a normal patient, the green lines indicate the location of the tentorium. The flow void of the basilar artery comes vertically upwards. It bifurcates at its terminal end into the posterior cerebral arteries, which remain above the tentorium, and immediately under the tentorium are the superior cerebellar arteries, also branches from the basilar. The oculomotor or third nerve and the trochlear nerve are caught in a vascular crotch between the posterior cerebral arteries and the superior cerebellar arteries. So when the temporal lobe herniates into the opening into the tentorium, it will compress these nerves, causing dysfunction and pupillary dilatation. So again, our patient has this extraaxial biconvex collection of hyperdensity consistent with an acute epidural hematoma and causing subfalcial herniation. Fortunately, this gross autopsy picture is from a different patient, but it also illustrates how you get a biconvex impression on the cerebral hemisphere, causing herniation. The epidural hematoma is trapped between the periosteum and the naked bone of the inner table of the skull. Patients who have epidural hematomas oftentimes have a delayed clinical presentation, and they are sometimes described as tuck and die patients. Here is another patient with an acute biconvex extraaxial epidural hematoma. We can see some overlying scalp swelling. If we look at this patient with bone windows, we can clearly see that there is a complex fracture involving the temporal bone. How does the fracture cause the epidural hematoma? At the time the fracture is created, the patient may have a temporary loss of consciousness or endure a concussion. As the fracture is created, there is mechanical stripping of both layers of the dura, the periosteal and the meningeal dura, away from the bone. There may be laceration of the outer or periosteal layer of the dura. The meningeal arteries, which are between the two different layers of the dura, may be lacerated. The inner or meningeal layer of the dura is a little thicker and a little bit more elastic, and it remains intact. Because the artery is lacerated, we have an extravasation of blood between the naked bone and the displaced or dissected periosteal layer of the dura, and expansion of the hematoma continues to dissect the periosteum off of the bone, producing the epidural hematoma. We can see in the black and white drawing how a temporal bone fracture would cross the grooves in the skull produced by the normal pulsations of the branches of the meningeal artery. In the specimen of the skull, we can see where a fracture would cross the grooves in the skull and would lacerate the branches of the middle meningeal artery. The epidural hematoma expands and displaces the dura away from the bone, compressing the underlying brain and the underlying ventricle. This is a selective catheter angiogram with injection of contrast into the external carotid artery. We can see that there is a biconvex collection here that is displacing the meningeal branches away from the inner table of the skull. Again, here we can see how the vessels are being displaced away from the skull as both layers of the dura are pushed away from the bone. In the lateral projection, we can see the extravasation of contrast material where the meningeal arteries have been lacerated as the fracture line has crossed the grooves holding these arteries. In the frontal projection in the same patient with the selective internal carotid injection, we can see how the brain is being displaced away from the inner table of the skull, producing the translation of the brain and the tentorial herniation. Epidural hematomas are typically associated with significant trauma that causes the fracture and the loss of consciousness. The patients oftentimes have what is described as a lucid interval where they wake up after the initial concussion, and then the patients may have delayed progression of neurologic signs and symptoms, which, unfortunately in some patients, progress to brain herniation and may often lead to coma and death. This lucid interval is seen in less than half the patients who have an epidural hematoma. Here is another patient with a subfrontal epidural hematoma, biconvex. In this particular case, the hematoma is small and does not cause any midline herniation or shift. If we look at the bone window images, we can clearly see the fracture involving the frontal bone. This is another case where the fracture line has crossed the coronal suture, and we can see here in this patient that we actually have multiple epidural hematomas with a central indentation formed by the attachment of the periosteum at the suture. The treatment for an epidural hematoma is a craniotomy, drain the blood clot, and if we can find the artery, it should be repaired. This was shown on Star Trek and in almost all neurosurgical texts. This has been Jim Smyrniotopoulos, and I have approved this message. Thank you very much.